Good afternoon, everyone. So the role of ophthalmologist in the management is a very, very important one because most of the time the ophthalmologist may be the first to encounter in CCF, not the neurologist or neurosurgeon. As we know that there is some theoretical part is abnormal communication between the cavernous and carotid arterial system. It may be a pre-existing some anatomical abnormalities or following trauma. Most of the time hypertension and other systemic diseases are one of the factors, and it was first reported in 1930. If it is a high flow, it is very, very easy to detect. So there may be swelling, all triad of the three are there. But if it is a low or indirect, sometimes it may be very, very difficult. Then the role of ophthalmologists are very, very high. So this is one of my patients. She was actually in ICU for a pregnancy-induced hypertension, and later on she developed. She told after that, so the diminution sudden, and ophthalmological opinion was taken. Someone detect as BRVO. Yes, of course BRVO, CRVO is okay, no issue. But what is the cause? Hypertension also may, but this is not only only the retinal vein. Then when we look in that, there is a congestion in the circumciliary congestion. Apart from the retinal findings, there is a blood in Slam's canal. So next investigation, MRA, it was detected as a CCF. Some are in post-trauma, it will be very easy. Of course, I already mentioned. So then there is a engorged vessels even in the lid, so we can detect it as a thing. But our role is not only to detect. From our hypertension point of view, we can look all cardiological evaluation, then care for corneal. Sometimes there is a proptosis, is one of the triad, one of the finding. In case of a direct, there is a proptosis. So our treatment starts from the corneal protection. So we can go for, and the IOP, always there is a range of IOP. So we can take care for IOP, etc. So those are one of my patients. It is a long-standing hypertension. There is there may be a pre-existing some anomalies on the some vessels. So there is ultimately there is a CCF. It was also misdiagnosed as a hypertensive retinopathy. Yes, there is maybe hypertensive, but may associated there is a CCF. So those are the important points. So we can look all. So coiling is one of the options done. As I already mentioned, the CCF, there is a triad. It's as per the book description, pulsating of the ophthalmos, ocular chemosis, and orbital bruits. But it may not be in all the cases. Only one or two may be present, especially in indirect variety. So we can look all. There is a cranial nerve paresis. There may be IOP rays. There may be on gonioscopy. There may be a blood on Slam's canal. Those we can do. Another important is that what is not in the book even all, the corkscrew appearance of the vessel. Once there is a corkscrew appearance in the vessel, and in the ultrasound, there is a hockey stick sign. Hockey stick sign is and due to the enlarged superior ophthalmic vein. Once in all CCF, there should be enlarged superior ophthalmic vein. So due to the back pressure. So this is another diagnosis in our hand from ophthalmological point of view. We can do a ultrasound, we can do a gonioscopy, and then we can detect most of the time. Then our investigation will come. The investigation of choice is generally MRA. But it depends on you. If your neurosurgeon or interventional radiologist wants to perform in a same setting, if you almost you can confirm it. So it is a CCF. Then in a one shot it can be treated. As I am now working with it in Apollo Hospital, it will be easier because interventional radiologist and the neurosurgeon is must too. Then we can treat in a same sitting. Otherwise, when I was in a 20 years in a one eye setup, so then it was difficult. So that investigation is first MRA or MRI, whatever. But now I just detect in each and every case, and then in one shot finish it. This is one of the patient that I want to mention. 22 to 23-year-old boy is a cousin brother of one neurosurgeon and plastic surgeon. They operate by plating. Due to the road traffic accident, he was in unconscious mode for 2 to 3 hours. Then he was in ICU. Then there was some injury. Next day he was operated by plating. Okay, fine. when his brother sent me to that examination of the eye, he told there is a dull egg only, eye egg. When I examined, the corkscrew appearance was there, but there is pressure was high, 28. And then I did a gonioscopy. Of course, there is a blood in Slam's canal, and there is a faint bruit was present. As there is a history of artery, RTA, so I thought it may be CCCF, but the question was the diagnosis. Of course, our clinical diagnosis was CCF, but how we can confirm it? As per the book recommendation, we should go for a MRA. But as there is a plate is there, that radiologists refuse. They will not go for any cost. Then I told, so you can go for at least CT angio. The CT angio is the next option. The reason of the CT angio is that we can detect the loose screw. If it is in orbital, MRI is not contraindicated, but if there is a loose screw or something, then we have to go for a MR. So MRI or MRA. So in a same shot, it was confirmed there is a no loose screw, etc. Plate was in situ. So we performed the surgery immediately after the 2 hours, after the GE recovery. You can see that there is a bright white eye in both the eyes. So it was coiling was done. Though this is just like for you, our interventional radiologist performed. This is true eye vein, and that's coil. It can be. It is by visualization, they can pack it nicely. Those are the coils. It may require 2 coils, 1 coil, whatever. We can just pack it. This is a simple procedure for them. But for our use, there's a paramount necessities are thorough history, detailed examination. There should not be any shortcut in our examination. Of course, for investigation, choice is the MR angiography. If there is some other causes for pacemaker, etc., then we can go for CT angio also. So my take-home message is, ophthalmologists may be the first to encounter a patient in clinical manifestation of CCF. At the present paper, it will help to understand the clinical features, current diagnostic approach, and possible modes of treatment and outcomes. Thank you.